Hi kids, so as you can see, hello midterms na po tayo. So meaning for our discussion today, this is already the first part or first part of your midterm coverage. And since we're talking about midterms here, again, let me just emphasize na dili ni siya appeal sa inyuhang prelim exam by next week. So, as what we have explained during your orientation, medyo naka-advance ang isa ka topic sa inyong midterm. The same thing with your finals para dili ta mabitin in terms of time and napuntay enough na time to discuss all the topics that needed to be discussed here in your bio-epi na subject. So, our topic for today is all about understanding the quality of data in clinical medicine. Now, di ba always be nato ma-encounter gyud ning word, di ba kaning word na quality. Yun. 'Di ba? In every aspect sa ato ang life na magyud ning quality, quality na education, quality na food products. Now, how about quality in terms of our profession? 'Di ba? Now, as a medical technologist, the most important thing that we need to do is, of course, to give the right result to our patient. Kay kita man gyud ni ang naga-process sa ilahang sample, kita man gyud ni ang muhatag sa kung unsa ang atong mga sample nagusultan agon sa atong physicians. And as to this topic, you will appreciate how important it is to process samples correctly and give accurate results to the patient because this is one way of helping our doctors. Diba? Mo man ni ang atong way na para tabangan ang atong mga physician and even the patient itself to give the right diagnosis and to be able to na para ang ato apong mga patient mag-undergo puro proper na mga interventions, proper management, tama na medicines. Now, for us to do that, we need to double check the quality of everything that we are using in the lab. Diba? From syringes during blood extraction to our machines and different equipments used for processing, because that is what we're trying to achieve, to give the best quality to our patients, whatever quality that is. So for our objectives, that is to define the validity and reliability of screening and diagnostic tests, to compare measures of validity including sensitivity and specificity, to introduce positive and negative predictive value, and to address measures of reliability including percent agreement and kappa. O, basig mo katawa mo ha, this is a different kappa. Now, for our topic outline, basically, it involves three parts. 1, 2, and 3. But in terms of how I made my PowerPoint and video lecture, actually, dili kay ninyo makita na terms. But of course, kanit tanan mga subtopics ninyo ha makita dire, makover man po na siya. So let us begin with the measures of validity. Unsa man ning validity? Now, in terms of our kaninas na topic nato, it actually addresses the question of how we could assess the quality of newly available screening and diagnostic tests to make reasonable decisions about their use and interpretation. And in terms of validity of screening test, let us define first what is validity and what is screening test. Now, validity is described or is defined as the ability of a test to distinguish between who has a disease and who does not, while screening test is performed as a preventive measure. Preventive measure to detect a potential health problem or disease in someone that doesn't yet have signs or symptoms. Di ba mo magyud na ang purpose nga no ta mag-undergo og screening test? For early detection man gyud na siya. Of course, to help reduce the risk of disease and of course to detect a condition as early enough, as early as possible para matreat po dayon siya effectively. Now, in terms of validity of screening test, we have two important components here. in order to measure validity, and that is sensitivity and specificity. Sensitivity is defined as able to correctly identify who has the disease, whereas specificity is to correctly identify who does not have the disease. So careful lang po, pag sensitivity ang pinag-uusapan, who has the disease. Pag specificity, who does not have the disease. So, sensitivity from the word itself, diba, sensitive, meaning, maskin unsa pa naka-minute ang number, or maskin unsa pa nakagamay ang presence of the pathogen or microorganism that is inside our body, kaya kaayo niya ma-detect. Mo man na siya na, syempre, the more na ma-detect niya the more o ma-detect niya even in the smallest presence of that pathogen, the better. Whereas specificity from the root word specific, meaning kaya kayo niya i-rule out yun na kanina certain individual wala gyud siya ani na sakit. Now, what if a certain screening test has a dichotomous result? Diba? When we say dichotomous result, meaning nalang tay duha diri ka result na ginatanaw. And most of your screening tests are actually in this manner, especially when we talk about mga laboratory na screening test. Diba? Usually, ang inyuhang dichotomous result na ma-encounter ani is kanang positive and negative. Now, why are these issues important? Kaning regarding false positive and false negative. So, dira nato na siya i-refer karon sa kaning table na inyuhang makita diri. So, take a look at first here at table 5-1. Now, this is an example of a population of 1,000 people, of whom 100 have the disease and 900 do not have the disease. Now, a screening test is used to identify the 100 people who have the disease. And mo na dayon ni ang inyuhang makita. Na 'di ba? You are already familiar with this one. We've always been using a 2 by 2 table sa atong mga computation, especially sa katong ato ang previous na topic. So, as you can see, each of these numbers na inyuhang makita diri ang part represents a certain na kanang category of those individuals present. Na kung kung tan-awon diri sa inyong 2 by 2 table, diri ang characteristic sa inyong population. So katong naay disease and katong walay disease. Diri na portion sa inyong left side ang result. So muna na diri si positive, na diri si negative. Now, kaning 80 na naa diri, still same ang inyuhang cell lettering and designation ha, that is A, B, C, and D. So, kaning 80 na naa kay cell A, what does it represent? So, refer ta diri sa inyuhang table 5-2. Now, kaning 80 actually represents those individuals who are truly positive. Why truly positive? Meaning, naagyod sila disease, nag-test pa gyud sila og positive sa atong screening test. Asa karon ang true negative? Syempre na diri sa baba. Nga sa inyuhang cell D. True negative because they do not have the disease, and when they were screened, ang result is negative. So, ang atong issues or problems karon are here in your cells B and cell C. Why? Because kani sila ang kumbaga error diri sa ato ang data. Okay? 'Di ba? Diri sa inyo, these are your false positives. This one is your false negatives. Error in such a way na wala ba gyud sila sakit. And yet, when when they were tested using the screening test, gawas na positive sila. Or the other way around, just like here sa inyong false negative, nagyon sila sakit, but then again, pag screen sa ilaha, paggamit sa screening test, ni-test sila og negative. Now, ngano issue man kayo ning false positive and false negative? So, isipan ninyo, if in terms of the false positive, if you do not have the disease and then you were tested positive, what will you feel? Number one, mangyud kaayo na maano nato ani sa atong patient is ang ilahang emotional feelings. Diba? That could really cause anxiety, that could really cause na kanang worries. Diba? Ikaw to na mag-positive, unsa man ang imuhang ma-feel. Another thing about false positive is that it is also associated with cost. Ano man, cost in terms of uh, the need na magpa-retest mo, and it could also be a burden to the healthcare system. Kaya syempre, sila man ang kanang magpa-test sa imuha balik. Labi na if we talk about there a large group of people na kailangan ipabalik for retesting. So, kana, burden jud po na sa part sa healthcare. And another worst thing about kung under ka sa false positive is the difficulty of delabeling that person. Diba, once pa na mo yung kag positive ka, maski na sa next mo na mga test kay nag-negative na ka, lisod na kay wala o ng thought na nag-positive yung ka ato na test. And ang problem ana manggong mag-positive ka sa test kay number one, employment. Wala na mo dawat sa imuha. Or pwede pod second, dili ka basta-basta makakuha na og mga insurances. So, kana ang mga problem sa false positive. Now, how about kung false negative ka? Siyempre, kani ang delikado. Diba, when we say na false negative ka, wala kay sakit, pero gi-consider ka na naa kay tungod pagpa-test nimo ni positive man ka, saying na naa jud ka ato na kondisyon. Sorry, sorry. When we say false negative, balikon lang nako ha. Naa ka ato na disease, but then again, pag screening test, nag-test ka og negative. Siyempre, at first, mahappy man gyud ta anak kay hala wala man gyud ko ato na sakit. But what if ing ani naa jud kay cancer? For example lang naa di kay cancer. Eh di ba? Kani mga cancer biya curable lang sa mga early stages. Now once nag-false negative na result ka, worst case scenario gyud na mahitabo ani pwede gyud ka mamatay. Di ba? Not knowing na di ka ato na kondisyon. Thus, ang importance yun aning false negative result would depend on the nature and severity of the disease being screened for. Kay always take note na ang effectiveness biya gyud sa intervention na o sa mga intervention na ihatag sa physician will always be greater if it is administered and if it is detected at the early stage sa atuang sakit. So again, that is the problem for your false negative. Dili makita na naa kay sakit. Then, walay intervention, walay management. Then, worst case scenario, it could lead to the death of the patient. Now, since katong discuss na ako kaganina is with regards to dichotomous na result, what if positive and negative lang, how about test with continuous variables, such as your blood pressure or your blood glucose level? Diba? Wala ba positive or negative na result for this one? Pag magpa-BP ba ka, mo lang positive, negative. Di ba dili? You are given actual values. So, how will you know now if you are kung truly taas yun ang imong blood pressure or imong blood glucose level or kung truly baba yun po na siya. So, for those tests with continuous variables, what we need here is actually setting a cutoff point. Now, before discussing further what is a cutoff point, or what is this cutoff point all about, let us refer first to this image. Now, kanisha na portion, this is emphasizing how important it is to set the correct cutoff value for each of your tests. So, ato siyang isa-isahon. Suppose na naamoy 20 ka diabetics and 20 ka non-diabetics. And syempre, we are trying to figure out, diba, kung unsa ang cutoff point. Now, subjects are screened using fasting plasma glucose, and by this time, we will use a high cutoff point. So, muna sa makita ninyo, O, gibutang nato siya diri higher na cutoff point. Now, when we make a 2 by 2 na table, so yung ani ang kinalabasan. Siyempre, dito sa diabetics na true positive, diri na part, true positives, those having diabetes and are positive or pasok dito sa inyong cutoff. So, there are 5. And then, those diabetics, non-diabetics rather, na considered na naa kay because of the high cutoff point, so muna 2. And then, diri na dayon, 15, 18. So if we try to compute for the sensitivity and specificity of that high cutoff value, we will have a sensitivity of 25% and specificity of 90%. Now, what does this mean? In terms of computing your sensitivity and specificity, we will discuss that later. So, ang ato asa diri is to give emphasis on how important sensitivity specificity is in setting your cutoff point in terms of continuous variable. Now, as you can see, dapat miagud ka ng sensitivity ug specificity mo reach man gyud na siya og 100. So we could say that since specificity is 90%, it is good since it is high, whereas sensitivity is actually very low. Kaya di ba na lang siya sa 25%. Now, what happens if we have a high cutoff value that will give us a low sensitivity, high specificity, and more, o di ba? More na, kaniday, more na false negative, di ba? Since most of the diabetics, di ba? Since most of the diabetics will not be detected. Now, how about if we will have kani a low cut-off na point, so placing your borderline here sa baba. So, unsa ang mahimo natong result? So, katong mga true positives, there are about 17. Those false positive, 14. False neg 3. And true negative, about 6. So, kung atong i-compute ang sensitivity ana og specificity, so kaninyo ha makita, there will be a sensitivity of 85% and a specificity of 30%. Now, what does this mean? When you set a very low or a low cutoff point, there will be a high sensitivity and a low specificity. And it would actually give us, diba, more hmm, more false positive results since there are only a very few diabetics, di ba, na misdiagnose. Kaya kung tanawon nyo, 17 biya po ang na-detect diri. But an equivalent proportion, di ba, of non-diabetics are also identified as positive by this test. So, mula po ng isa ka disadvantage. But remember kids, na 'di ba, in a typical population or kumbaga in the actual setup, there is no line separating the groups and the subjects are mixed. 'Di ba naka-mix naman gyud na wala man di man nato pwede iingon na during testing na ato sang igrupo ni sila na population. No, they are actually mixed and there is no color or label. 'Di ba by the time na imo adto na patient sa imuha na magpa-extract, 'di ba wala may nakabutang dira sila mga ulo na moingon na diabetic na sila daan or dili. So this is actually the very challenging part in terms of validity of screening test. Labi na kung unknown gud kayo ang imong population or katong mga individuals na imuhang gipang test. So that is why it is very important to set a correct nga cutoff point na para dili magsobra or dili magsobra ang mga false positive or negative pero dili pud pwede na ato pong i-compromise ang inyong sensitivity ug specificity. So, as mentioned, different cut points will be different sensitivities and specificities. The cut point determines how many subjects will be considered as having the disease. cut point that identifies more true negatives will also identify more false negatives, and the cut point that identifies more true positives will also identify more false positive. Diba? I-remember ni ninyong last two na statement. Since mo na siya kato akong gipakita kaganina with regards to sa diabetics and non-diabetic patients. Now, the choice of a high or low cutoff level for screening therefore depends on the importance we attach to false positives and false negatives. So, kana lamang yun na siya. It's a matter of trying to weigh out your screening test. Kay actually, dili man gyud nga nakadaghan ang atuang screening test in terms of availability. So, pwede po nato na i-consider na what if di ay ing ani lang gyud kagamay iyahang sensitivity and specificity, and yet wala man tay other test na pwede i-conduct. So, mao po ng isa ka consideration na ato ang tan-awon. Now, you might wonder, ma'am, how did we able to come up with reference ranges being set in different tests? Diba, ma'am, giunsa man di ipag-set sa mga reference range na katong makita nato dito sa ato ang complete blood count na result, sa ato ang mga chem test. Actually, uh, I think pa-further discuss na siya sa inyuhang clean chem na subject. But then again, just to give you an idea, pooling mangguna siya of people. Murag daghan kayo i-test na number of population, and then naanay computation na buhato na murag statistical computation po na siya. Pero sige lang, may balaan lang po ninyo na puhon labi na kung magtrabaho na mo and then you need to set your own normal range, especially sa inyong mga quality controls. Mabuhat man na ninyo puhon. So, now we proceed on how we could compute for your sensitivity and specificity. Since diba, gipang mention naman nato kaganina to mga percentages, so giunsa dito siya pagkuha. For your sensitivity, again, refer to this table, and the same ang designation. This is your cell A, cell B, cell C, and cell D. Now, for your sensitivity, that would be A divided by A plus C. Now, syempre, since again, just like how we define sensitivity, but we are looking at those who have the disease. So, kinsa to ang tinuod na positive versus ang total population sa naay disease, whereas in specificity, that is D divided by B plus D. So again, when we talk about specificity, this is referring to those who do not have the disease. Now, another way of writing your formula is this one. Depende ha kung asa mo mas comfortable, because there are uh, students who could remember better if pinaing-ani siya na style. Na po ibang students na mas ganan ani isa. So either way, that is correct, and they are actually just the same. So let us take for another example a fictitious data with regards to the serum level of calcium and true disease status of 80 participants tested. So as you can see, again, 2 by 2 table gihapon ni siya, but careful sa placement sa inyuhang data. Diri ang in terms of having the disease or not, diri ang sa inyuhang testing. So, how do we compute for sensitivity? That is, diba, kani A, pababa na siya. So, muna 12 divided by total of individuals having the disease. Whereas as inyuhang specificity, so kani po na inyong tanawon, 3, ay, sorry, maliday ko. That is, kaniday, 57, kaya diba true negatives man. So, 57 divided by the total number of people who do not have the disease, and that is 60. So, i-erase lang sa nato para di mo ma-confuse. Okay. So, kana na siya. So, the sensitivity would be 60%. Actually, baba na ganin 60%. And the specificity would be 95%. So, that is how you compute your sensitivity and specificity. Now, Now we go to your use of multiple tests. Siyempre, there are times na ang inyuhang physician mo order og daghan na screening test for the same na individual. And actually na may pros and cons ani, but then again, na reason po ng mga physicians as to why they will order a lot of tests. And the number one reason for that is to prevent na naa sila ma-miss out o para gihapon mo properly diagnose nila ang ilahang patient. Now, as to the use of multiple tests, there are actually two types of using multiple tests, and it could be simultaneous or sequential. Now, when we say sequential, di ba, meaning one after the another, when we say simultaneous, giconduct siya at the same time. So, unahon nato ni inyuhang simultaneous testing. Now, simultaneous testing is when two or more tests are conducted in parallel, agad-agad, sabay. Disease positives are identified as those who test positive by either one test or by both tests. So, pwede ta moingon na positive ka, either one lang sa test na mag-positive ka. All the more pa jud kung mag-positive you ka sa both, then all the more na considered you ka having the disease. Now, the goal in your simultaneous testing is to maximize the probability that subjects with the disease or true positives are identified. But the consequence for simultaneously giving the test in the same individual is that more false positives are also identified. So actually makita ni ninyo later sa akwang example as to how to compute for the net sensitivity of your simultaneous testing, both net sensitivity and net specificity. So actually mo na siya nga to ang next. How to compute for the net sensitivity using two simultaneous testing. What if naamoy duha lang ka test na gi-undergone? Siyempre, kwaon man yun nato na siya iyahang net sensitivity. Since duha man ang inyuhang gikuha na test, dili nato i-consider nato na sila as one. Now, these are your different steps in computing for the net sensitivity. Pero di na nako na siya isa-isa hunog basa. Basahan lang ninyo na siya balik, butang manina ko siya sa inyong handout, mudiretso na lang ko sa inyong example kay para at least makuha ninyo dayon and you will get the gist of it. So, try to look at this figure. So, an example, uh, this oval represents the 200 people who have the disease. Now, kunwari daw, sa kay test A na 160 na nag-positive. Sa kay test B na 180 na nag-positive. Now, syempre, between test A and test B, naamang yun na same individual, na mo na siya itong pangtaon, same na individual na nag-positive for both. So, how do we compute for that one? Kaya diba, before ta mo proceed diri, kanisa niya itong tanawon, how would we know how many individuals tested positive for both test A and test B? So, let us refer to this table. Again, this is the same. So, kumbaga, ato alang gihimo, gitransform lang to nato into a 2 by 2 table. So, dali tatanaw. Test A na ay sensitivity of 80%, while test B na ay sensitivity of 90%. Now, since test B has higher sensitivity, we could assume also na 90% aning 160 na nag-true positive kay mo positive po ani sa inyohang test B. 90% of those individuals na naaning 160 kay positive po aning test B. So muna na para makuha nato kani kung pila to ang nag-positive both test A and test B, use the sensitivity here in your test B, multiply it by 160. Sige daw, so ako lang pong i-double check ha. So that is 160 times 0.90. Tama ba? 160 times 0.90 and that is actually equivalent to 144. So, as you can see, tama ba itong answer? Yes, tama. So, pwede nato i-assume dire na 944 na both nag-positive kay test A and test B. Now, since we are talking about sensitivity here, i-consider gihapon nato kung pila gyud to ang nag-test og positive lang kay test A and nag-test positive lang pud kay test B. So, unsaon ninyo pagkuha? Just subtract 144 with 160 and we will get the 16, and then dere 144 minus the 180, dere ko mag-refer, the 180 na total na true positive kay test B, and we would get the number 36. So, how to compute now for the net sensitivity? You add all those who tested positive. 16 na nag-test og positive kay A, 36 na nag-test og positive kay B, 144 na nag-test og positive sa both test ninyo. Divided by ang inyong denominator ang isang total population. So we would get, di ba, a net sensitivity of 98%. So I hope nakuha to siya. Next, how about your net specificity? Kaganina, sensitivity lang man to. How about your net specificity? Now, as mentioned, dili gihapon ako ni siya same with your net sensitivity. Di na nako ni siya isa-isahon og basa. Basahan lang ninyo na siya balik sa inyong handout. Mudiretso na ko og set og example. Now, actually easier ang dirian na part sa inyong specificity. Since we are talking about specificity, all we need to consider and to know here is pila lang yun tong nag-test og negative sa both ninyo na test. Kana lang. So, muna siya na the same example with our net sensitivity. This time around, na ay 400, 480 na true negative kay test A, 720 na true negative kay test B. Now, to get kung pila tong ang number sa both na nag-negative ni test A ug ni test B, still use the specificity na 90% dire kay test B kay sama ng higher, compute it with the true negatives of your test A. So, kung ato nang i-compute, 480 times 0.90, so we will get the 432 who tested negative on both test A and test B. So, since naa naman ta na, then now we could compute. Buhaton lang gyud ninyo 432 uh, na nag-negative both kay test A ug test B divided by sa total number of individuals na walay disease, and our answer would be 54%. Okay? Sige. So now we proceed with our sequential two-stage testing. So kaya siya two-stage kasi there will be a first screening test that will be conducted, and then once ang kaning mga individuals and then once na ay individuals na mag-positive, i-retest na sila og balik, and that is your second testing to further reduce your false positive. Now, your first test is usually less expensive, less invasive, and less uncomfortable. But with your second test, expect that that would be more expensive, more invasive, and more uncomfortable. Now, the problem with your two-stage testing is that it could actually increase specificity, but it can reduce your sensitivity. Now, ako na siyang i-emphasize further by looking at this example. So, ingani ang way of computing when you are using the net sensitivity and net specificity when you are using a two-stage testing. So, assume a population of 10,000 people with diabetes prevalence of 5%. And then, Gamit mo og test na naay sensitivity of 70% and naay specificity of 80%. Now, from the 10,000 na population having a disease prevalence of 5%, meaning na ay 500 katao na ay diabetes, and then minus lang, then nada yung tayo 9.5 na walay diabetes. Now, to compute for your true positive and true negative, just use your sensitivity and specificity na value. So, substitute lang mo ana. Then you would get these values, 350 who are your true positive and 7,600 for your true negative. Now, since naa naman taani na numbers, 'di ba unsa ganito ang ato ang buhaton sa inyong two-stage testing? Tanan na nag-positive sa inyong test, i-retest. So meaning, dili lang ta mo consider kay 350, consider also 19. So mo na meaning na ay total of 2,250 na nag-positive sa test result that will be retested and will proceed with the second na testing. So muna na kung unsa ni inyong values diri sa inyong first test in terms of kinsa to ang mga nag-positive, that will become your total, diba? Total na population here. So, ibutang na siya sa baba na portion sa imuhang test 2, sa imuhang 2 by 2 table. Now, let us assume na sa test 2, higher na ang sensitivity and specificity, both 90% na siya. So, compute nato na siya. 350 times 0.9, you would get a value of 315. 190 times sa 0.90 sa specificity, then we will get a value of 1,710. Then, fill in na dayon, minus lang. So, naanatay 2 by 2 na table nato for your test 2. Now, since we already have these values, we are now ready to compute for your net sensitivity and your net specificity. So how to compute your net sensitivity and specificity? By using our n values. So kumbaga, buhato nato for net sensitivity, that would be 315 divided by the total population sa katong pinaka first pagyud, pila to tanan gyud ang original na naay disease, then that is divided by 500. And we would actually get a result of 63% sa net sensitivity. How about sa inyuhang net specificity? So we will do the same. Dirita mo kuha sa true negative ninyo na value, then that is 1,710 kung sa inyong denominator. Dirita balik sa inyong original population sa kinsa pila ang number atong pila ang number sa non-diabetic, then that is 9,500. So if we compute this one, we would actually get a 98% 98% na net specificity. So, sa inyong napansin? Diba? Sa inyong napansin? Kung tanawon ninyo from the original, diba? From the original na value sa sensitivity ug specificity, ang net sensitivity nato is actually baba. But with our net specificity, it actually increased. So, mo to siya akong gi-mention kaganina. Nga, diba? Mo ang consequence diri sa inyuhang two-stage testing. The overall process will increase your specificity but would actually reduce your sensitivity. So going back to our example, diba from pila to 80% ninyo na specificity nahimong 98, and then sa sensitivity ninyo na from 70% mas tibaba pa nahimong 63%. So mo na bantay-bantayan lang po dyan nato. Again, in terms of what type of multiple testing you will do, consider still kung saan best for diagnosing. So to compare, between sequential and simultaneous testing. So, ingani lang. For sequential testing, if you still recall or if inyuhang na-observe a while ago, diba na ay net loss sa sensitivity pero na ay net gain sa specificity. Whereas, in your simultaneous testing, baliktad, net gain kay sensitivity, net loss kay specificity. Now, the next question would be, kanusa man daigid nato gamiton ni sila? First, depende sa aim sa testing. Are you trying to screen lang or are you trying to diagnose? If you are just screening, then better use simultaneous. If you are already trying to diagnose, pwede na actually si sequential. Uh, Depends also sa cost. Diba? Number one, afford po ba sa inyong patient na 'di ba sa sequential testing you would expect na mas mahal magyud tong second test na inyuhang buhaton. Depende sa degree of invasiveness, practical considerations, and last, third-party insurance. 'Di ba? Depende man gyud na sa inyong insurance po kung kaya ba na niya sa luon labi na kung naay insurance ang inyuhang patient. So the principles of testing can be summarized as follows. If you are trying to look at a good screening test, it should really have a high degree of sensitivity. Kaya di ba, mao gani ta naga-screen kay gusto nato tan-awon kung presence gid ba ang disease sa inyuhang patient. Mao na after screening, proceed man gyud ta ana to confirmatory testing. And for your confirmatory test, dapat ang taas diri ang specificity. Na kumbaga, dapat kaya ma-rule in sa inyuhang test na wala gyud na siya ana na kondisyon. And diba, naalang diri some recommend the mnemonic spin to remember that specificity is needed to rule in, and snout to remember that sensitivity is needed to rule out. So again, rule in, rule out. Okay. Now we proceed to the goals of data collection and analysis. Now, clinical medicine requires constant collection, evaluation, analysis, and use of quantitative and qualitative data. And this data is used for diagnosis, prognosis, and choosing and evaluating treatments. Now, data may be accurate to varying degrees. To the extent that your data is inaccurate, we therefore say that there is an error. Now, when we say error, it could be mistakes in the diagnosis and treatment of your patient, or it can be mistakes due to negligence. Now, of course, in terms of our profession, or in terms of kaning mga health related bang gyud mga profession, always remember that there is no room for error. Though it is, kumbaga, dili man gyud nato maiwasan na magkaroon ani na mga mistake. Human as we make mistakes, but as much as possible, as little to none lang yun ning errors. And mao man gyud na ang ato ang praktisan mo na naggrabe ang paghasa gyud sa inyo ani sa sa kanina profession kay para by the time na isabak na gyud mo sa tinud-anay, labi na kung mag-work na gyud mo kay at least you are sure na tama yun yung ginabuhat and you are giving the accurate and correct results. So, limitations of medical history's results and reports, what does this mean? Siyempre, if you could still recall katong gidiscuss nato sa previous na topic na regarding bias, labi na regarding kanang pag-report o pag-survey, mao man ang mga certain limitations na mahitabo dire. Diba? Medical histories, results, reports, laboratory values, physical examinations, they are never perfect because naman yung limit ang human process. Medical history pa lang, di ba, kunwari gina-type na siya, what if na typo, or mali di ito na data, na abi nimo habang nag-type ka kay, abi nimo sa the same patient gapon to na data, nasulat nimo sa lain. Or sa laboratory na result na kunwari pag-report nimo nagka-switch da itong mga samples nimo. So kana dako na kay na problem. So mo na siya ang goal gyud nato diri in terms of data collection and analysis is to minimize error in data so as to guide and not to mislead. So, how do we uh, how do we isang tawag na saan nato na para makuha nato ni siya na goal. So kanina atong buhaton. First is to promote accuracy and precision. Second is to reduce differential and non-differential errors. And lastly, to reduce intra-observer and inter-observer variability. So let us start with promoting accuracy and precision. Let us define what is accuracy and precision. Accuracy means closeness to the true value, and it is the ability of a measurement to be correct on the average. Whereas, for precision, which is also known as reproducibility or reliability, it is the ability of a test to give the same result or a similar result with repeated measurement of the same factor. Now, to give you an idea on the difference between accuracy and precision, take a look at this first. Now, this is with regards to your Gaussian bell curve, di ba? Familiar namang yun kaayo mo ani. Now, let us take a look at letter A na figure. This Gaussian bell curve, as you can see, this refers to having both accuracy and precision. Why? Always lang yun ninyo i-remember ang definition. Accuracy, closeness to the true value. So, di ba, mao man ni meaning or pwede na to isipon ana na kaya siya accurate kay ang mean nato is duol gyud kaayo sa or exactly at the true value. And precision, this is precise since, di ba, grabe ka narrow sa inyuhang bell curve referring sa kung unsa ka close inyuhang mga results with each other. Now, look at figure B. Diba, this is only accurate. Si mean na manghapon dira sa inyong true value, pero grabe ka spread out sa inyong data mo na grabe pud ka open halos sa inyuhang curve. Diri kay letter C, precise lang. Kay diba asa si true value? Naabi si true value diri. So meaning, wala dito sa true value ang inyong mean away from the true value, but then again narrow inyong curve kay kung tanawon ninyo ang individual results, close gahapon sila with each other. And for letter D, kanihan neither accurate nor precise. Layo na gani ka sa true value, grabe pag yun ka spread out ang imuhang data. So para na amoy mas nindot na view ani kay basig medyo confused mo kay murag ano man kaining curve, pwede nato ni siya i-refer ani na image diri sa inyuhang figure 7-2. Diba? Mura ni siya katong inyuhang dartboard lang. Na diba, ang centermost, medyo ninyo mo man yung bullseye. And let us consider that one as your true value. Now, for letter A, so kaninyo ha makita, compare it with this. This is what is both accurate and precise is referring to. Na diba, close to your true value, even ang taga-dot ninyo diri is close with each other. Accurate only, kay close man hinuon gyud gihapon ni sa true value, but then again, look at how spread out each of your dot is. Next, precise lang ni kay dara ba si true value ninyo. It is very far away from your true value, but then again, if you look at each result, they are close to each other. So kani, all the more, dili na gani accurate, kay layo na sa inyong true value, dili pag yun close ang inyuhang mga dots. So that is how we describe accuracy and precision. Next, reducing differential and non-differential errors. Now let us define what is differential and non-differential errors first. Differential error happens when the information error differ between groups. Non-differential error happens when the information is incorrect but is the same across all groups. So I hope nakita na dayon ang difference. Kaya siya differential kay taga-grupo gyud lahi-lahi. Kani non-differential siya na although mali man Pero ang katulad na mali, the same all throughout sa mga groups na present. So, an example of your differential error is your measurement bias. Now, actually, na-discuss nato ni si measurement bias sa ato ang previous na topic na, di ba? It refers to any systematic error that may occur during the collection of baseline or your follow-up data. And an example for that is number 1, blood pressure values. Na, di ba? Uh, na ay inaccuracy na mahitabo when you measure your blood pressure. Like for example, so kani bag-ora pod na ako ni nahibalan na if you have a full bladder DI, it can add of about 10 to 15 points daw sa inyong blood pressure reading. Or for example, kana di ay mag-wrap ka sa imuhang blood pressure cuff na over sa clothing kanang wala nimo gitanggal ang katong sleeve, dili man sa gitanggal, wala nimo gipataas, then at least mag-vary po jud daw ang inyuhang measurement ana. It could add daw about 5 to 50 points sa inyuhang blood pressure reading. So mo na siya ang isa ka example sa inyong measurement bias. And di ba, kaning second example na ako ang gihatag, mo ni siya actually ang akong gihatag na example sa inyo sa katong previous na topic, di ba, na kung mag-measure mo og height na na shoes on, di ba, measurement bias na siya. Di ba, originally 5'4 lang siya, then tungod wala ninyo siya gipahubo sa iyang sapatos, and then iyang sapatos kay taas kayo og takong nahimo na siyang 5'6", that is already a measurement bias. Or in terms of sa laboratory, pag kanila certain substance, ang way ninyo na pag-measure sa iya kay different na methods, that is already a measurement bias. Since different methods, namang gusto na siya different na kanang style or sabay term gani ana, na ay different na principle, and pag matter man gyud na siya, and naaman jud na dako na variation gyud sa inyong result, since again lahi-lahi man siya na method. So how about your non-differential error? So unsang example ani, that is your random error. Random error has been discussed also in your previous topic. Diba, again, random error is a variability, and naiingani na property na it is variable and it is unpredictable. Na pwede na kalit-kalit ang yun siya mag-appear sa atuang system or sa atuang data. And random error actually lacks in precision. And when your data have only random errors, some observations are too high and some are too low. So if you could still recall, ang example na akong gihatag ani sa inyo is in terms of testing. Like for example, during nag-test mo, kalit lang na nibaba ang temperature ang temperature na, di ba, dapat ang temperature sa inyong machines kay nasa -20, nya nikalit lang og 37 degrees Celsius. Or sa pa ba? Or katong sa inyong materials na gigamit, na di ba tungod kay nag-clean mo, bago lang mo nag-clean, and then nadahapon na siya certain variability dayon na present. So mo na siya ang isa actually sa mo na nakaingon tag unpredictable ni siya, kay di ba? Going back sa katong example na ko regarding nagkalit na change na temperature, that is actually unpredictable. You would never know na when namukalit lang og kaguba na ang yahang temperature na ginagamit ninyo dara sa inyuhang machine. Next is reducing intra-observer and inter-observer variability. So please be careful. Ang isa is intra, ang isa is inter. So when we say intra, that is within the observer. When we say inter, that is between observers. So start with your intra-observer. This is the amount of variation between the results obtained by one observer examining the same results more than once. So to give you an example, some clinician takes successive blood pressure on the same patient. Diba? Within observer lang man na, ikaw manggihapon na siya. But then again, when you try to take the blood pressure of the same patient na pabalik-balik, dili magyud na siya always mo point out sa same exact na value. For example, sa first take ninyo, nasa 120 over 90. And then, pag second take ninyo, natingala mo na nasa 110 over 100. Na although if you think about it, di man yun nga nakalayo ang difference. But then again, nagapon ng factor na variation. Next is derita kay inter-observer or between observers. Now, it is the amount of variation between the results obtained by two or more observers examining the same material. Uh, Actually, in terms of inter-observer, this is, kumbaga ka ng common sense kaayo ni siya na naman yun ay difference between akwang observation and observation sa another na tao. Diba? The same lang gud na naatay murag variability na moingon ta na damian kaani na food pero ang sa isa dili siya ganahan na although it is the same na food. So best example for this is in terms of X-ray reading, 'di ba? Na kaning isa ka observer pag read niya ani na X-ray sa kanina patient kaniyang observation. Then gipakita ninyo sa lahi na pud na kanang doktor and then lahi pud iyahang na come up or iyahang na observe or iyahang result. So mo na ang inter-observer variability. Very common ni siya labi na kung dito ta magtan-aw sa kanang nagapa-second opinion na 'di ba usually some patients nagapa-second opinion man gyud na sila og reading sa ilahang mga result kay to double check lang gyud na if ang kanibang second the physician same pud ba gihapon iyahang diagnosis sa ako. And if mag-differ, then dara ang naay dako na problema, 'di ba? Pero if the same, then the better. Okay? So, ikat sana ako ang atuang lecture diri. As you can see, it's almost an hour. And then again, for the second part of our video lecture, mas daghan gihapon mog computation na ma-encounter dito. So, take a break muna and then after some time, after ma-refresh, kay murag daghan naman po na information ang akong nahatag, try to watch the second video na po. So, thank you and that is all for your first part.